All right, I think we can go ahead and get started. Um, as my first duty as MFM faculty, I have the honor of introducing Dr. Michelle Moniz as our Grand Round speaker for this morning. I think Lisa just texted in the code for Grand Rounds in the chat. Um, but to introduce Dr. Moniz, Dr. Moniz is a assistant professor in the Department of Obstetrics and Gynecology and the Institute for Healthcare Policy and Innovation at the University of Michigan. She received her medical degree from Washington University in St. Louis and completed residency training in obstetrics and gynecology at the University of Pittsburgh Magee Women's Hospital. She went on to complete the Robert Wood Johnson Foundation Clinical Scholars Program and her master's degree in health and healthcare research at the University of Michigan. Dr. Moniz has a busy generalist obstetrics and gynecology practice at the Northville Health Center and loves working on labor and delivery at the Mott Van Voigtlander Women and Children's Hospital. She is a part of the Program on Women's Healthcare Effectiveness Research, an interpersonal consortium of health services researchers focused on improving value and outcomes in reproductive health care. Dr. Moniz's research efforts are focused on identifying evidence-based strategies for implementing evidence-based reproductive healthcare policy and practice. She has published extensively on implementation of evidence-based peripartum contraceptive care, including on utilization of recommended care, costs of implementation efforts, and the attributes of successful implementation champions. She is also a nationally recognized expert in reproductive healthcare policy, having conducted numerous evaluations of the impact of healthcare reform on access, affordability, and utilization of reproductive and preventative services for women. She is passionate about translating research into real-world impact to improve the healthcare system and enjoys translating complex scientific findings into simple, compelling, memorable language for the media, the public, and policymakers. Please join me in welcoming Dr. Michelle Moniz.
Thank you so much, Jenna, for that introduction, and thank you all for having me. I am so sorry I couldn't be there in person today, but I'm really excited to have this hour to share with you to talk about U.S. healthcare reform and women. This talk's a little bit different than some of the content we often cover at Grand Rounds. I'm not really going to be talking about clinical innovations today, but rather I'm going to have us zoom out a little bit and think about our entire healthcare system as our patient today, and think about whether we're doing a good job with our health policies, the structures that determine whether patients have access to our clinics and our hospitals and our operating rooms in a meaningful way, and what are the results of that care we're delivering in terms of population health outcomes. So thank you for having me. I couldn't be more excited to be sharing this time with you. So my learning objectives are here. I hope that by the end of this talk, everybody will be able to identify women's unique healthcare access barriers before the passage of the ACA, the Affordable Care Act. This is really the most sweeping change to the U.S. healthcare system since the 1960s, when Medicare and Medicaid were passed. The Affordable Care Act was passed in 2010 and implemented over the next few years. And now at 10 years out, we have some really interesting data about what the effects of this policy have been. So we'll start by thinking about what the access barriers were before the passage of the ACA. And then I hope that everybody will be able to analyze how the ACA affected coverage, affordability, utilization, and health outcomes for women. And finally, by the end, I hope you'll feel inspired to start imagining what some potential policy changes might be to promote more equitable care and outcomes. So these are my disclosures. I am a paid scientific consultant for the RAND Corporation and for the Society for Family Planning for review of scientific deliverables. I do also receive grant funding on a K award through the Agency for Healthcare Research and Quality. I think perhaps my most important disclosure is that I believe health is a human right, and that lens certainly colors how I see our U.S. healthcare system. So I do want to be clear about that. And we'll also mention that throughout this talk, I use the word woman, women, and I know not everybody identifies with she series pronouns. I use this language because it really reflects the data that we have at this point, and we'll try to be inclusive in my language wherever possible. So because I don't have the pleasure of getting to meet you all in person, I thought I'd just start by telling you a little bit about myself. I had the real privilege of training at the University of Pittsburgh for residency, where I was able to interact with Heidi Brown, with Katie Cook, and just make really great relationships with folks who are in the trenches training with me at the same time. And that was also where I think the seeds of my professional career now were really planted. I saw firsthand the many, many challenges with our healthcare system that I wasn't going to be able to address one-on-one with the patient in the office, and wanted to be able to secure some additional training to do a different type of work on our healthcare system. So I came to the University of Michigan in 2013, where I did a master's degree program through the Robert Wood Johnson Foundation Clinical Scholars Program. And this is a training program in health services research for physicians. And in 2015, I then joined faculty here at the University of Michigan and am now on a research pathway. And I'm really privileged to work at IHPI. This is the largest academic consortium of health services researchers in the country. There are over 600 investigators working across different schools to try to improve our healthcare system. And I'm also embedded in POWER, which is our program on women's healthcare effectiveness research, and is a group of interdisciplinary health services researchers working specifically on women's health. So these are the experiences that I bring to the table, and why I'm passionate about the things we're going to talk about today. So my professional mission is to translate evidence into reproductive health policy and practice to try to improve women's health outcomes and eliminate inequities. And my research to date has really taken kind of two arms. One arm focuses on policy, healthcare reform, the Affordable Care Act, and its effects on women. And the second piece focuses on practice, how we can get evidence baked into our everyday care delivery at the front lines. And a lot of that work has focused on postpartum contraception and more recently evidence-based prenatal care. I'm not going to talk so much about practice in our talk today. We'll really focus more on the capital P policy piece, but happy to talk offline about implementation science if anybody's interested in that. So my outline for the talk, we'll start by talking about what the state of healthcare looked like for women before the Affordable Care Act. And then I'll transition to talking about the ACA, some of the specific policy pieces that were designed to affect women's healthcare, and then what we know about the effects on coverage, affordability, utilization, and health outcomes for women. And then we'll conclude by talking about some emerging policy priorities and what's kind of coming down the pipeline. So women in healthcare in the pre-Affordable Care Act era, women really faced unique challenges in accessing healthcare in our system and improving health outcomes. Employer-based insurance is the primary way that folks access health insurance in this country, and women have less access to employer-based insurance than men because they are more likely to be unemployed, more likely to be employed part-time, more likely to be providing unpaid labor and caregiving roles in households. And so this was a challenge for women. Women had much higher uninsured rates than men prior to the ACA. Women were also more vulnerable to insurance loss because they were more likely to be covered as dependents. And so in case of a spouse losing a job, divorce, a spouse passing away, women could lose their coverage. Women also are more vulnerable to out of any given level of out-of-pocket cost for healthcare because they tend to be paid less for the same work, and women are also have higher rates of utilizing healthcare. And we know that all of these barriers were likely compounded because they intersected for certain subsegments of our population: women of color, members of the LGBTQ community, those living on lower incomes. So not a great place for women to be starting out before the ACA. In fact, women could be denied healthcare coverage because of pre-existing conditions, which for women included pregnancy, infertility, intimate partner violence. Women could also be charged higher premiums for the exact same benefit package. This was a phenomenon called gender rating. And it made healthcare much less affordable. It made insurance coverage less affordable for women. Health insurance plans also commonly excluded needed services for women. So a significant number of both commercial insurance plans as well through the employer market, as well as individual insurance plans, excluded coverage for things like contraception, things like pregnancy, that women were likely to need coverage for. Pregnancy care is the most common reason that women utilize a health insurance plan. There were also really big challenges around perinatal insurance churn. This is the phenomenon of folks gaining and losing health insurance coverage, so discontinuity in coverage over time. And this, of course, created a lot of challenges for women to actually be able to access recommended care during pregnancy. And before the ACA, there were really striking disparities in uninsured rates by racial ethnic group, by income group, and these were some of the challenges that the ACA set out to try to address. So the goals of the ACA are here. Really, the primary goal of the Affordable Care Act was to improve coverage. It was to reduce the rate of people who were uninsured. And it did this, tried to achieve this goal through a variety of public and private initiatives, which we'll talk a little more about in a minute. The ACA also sought to improve the affordability of healthcare, to eliminate out-of-pocket costs for services. So out-of-pocket costs include copays, deductibles, and coinsurance payments for services that are utilized on a plan, and to make sure that folks were not feeling unable to access recommended care because of financial barriers. And the idea was that through improving coverage and affordability, that there would be downstream benefits for utilization and health. So these were the major policy changes implemented by the ACA that were likely to affect women. In terms of coverage, Medicaid expansion was the ACA's attempt to ensure that all individuals living on lower income would have access to health insurance coverage. Prior to the ACA, Medicaid income eligibility for Medicaid was state specific. And so some states had income eligibility criteria as low as 18% of the federal poverty level. So the FPL is about $16,000 per year for an individual, about $24,000 per year for a family of four. So in some states, if you made 17% of the FPL, you would not qualify for Medicaid coverage. And the ACA said, we're going to set this bar at 138% FPL across the country. Now, this provision of the ACA, of course, faced Supreme Court challenges, and states were allowed to decide whether to expand. 39 states, including DC, to date have expanded Medicaid, and there are really great studies comparing expansion states with non-expansion states that provide a lot of the data that we'll discuss in this talk for what the effects of Medicaid expansion have been. The ACA also provided marketplace subsidies. So for folks who didn't have access to health insurance coverage, either through Medicaid or through their job, they could go online to health insurance marketplaces and buy an individual plan. And the ACA provided subsidies for both premiums, the monthly fees that we pay for health insurance, as well as cost sharing subsidies to help defray the costs of copays, deductibles, and coinsurance for lower income families at 138% to 400% FPL. The ACA also had a dependent coverage provision. So before the ACA, young adults ages 18 to 26 were one of the groups in this country that had the highest rates of uninsurance. And the ACA sought to fix that by saying that these individuals could stay on their parents' health insurance plans up to age 26. And the ACA also banned pre-existing conditions from precluding coverage. And this was a major reason that individuals would be denied health insurance coverage and be uninsured. On the affordability side, the ACA implemented a variety of policies to try to improve affordability. So banning gender rating, women were no longer allowed to be charged more for the exact same plan. The ACA also banned annual and lifetime spending caps by plans. So commercial insurance plans used to be able to say, oh, you've hit your lifetime max, we're not paying anymore for your medical care. And the ACA also implemented a number of consumer protections. So The essential health benefits provision required certain services to be covered within plans. So maternity care is a great example. Prior to the ACA, plans did not have to provide coverage for pregnancy or childbirth related care. People would have to purchase a rider to add on that coverage. The ACA said, no, that is an essential health benefit. It has to be covered in your plan. It does not have to be covered first dollar, meaning it can, plans can and do, as you'll see, charge people out-of-pocket costs via copays, deductibles, and coinsurance, but it had to be a benefit that was included in the plan. The ACA also had a clause around preventive services that required certain preventive services to be covered without cost sharing to improve access to these services. And I'll show you a little bit of data about what the effects of these policies have been. So let's first talk about coverage. This has really been a place where the ACA has been quite effective. We saw a dramatic fall in rates of uninsured women ages 18 to 64, falling by 39% from a high of 18% in 2007 before the passage of the ACA down to 11% in 2017. So really, really wonderful improvements in uninsurance rates in our country. This aggregate finding, though, sort of hides the bigger picture with some differences across groups. So here, that orange line is that overall rate in uninsurance across our country among working age women. The blue line at the top shows you lower income households, women living in these households making incomes less than 200% FPL. The green line is women ages 19 to 25, so those who might have benefited from that dependent coverage clause. And you can see that there were really striking gains in both of these two groups as well. So really reassuring findings about the effects of the ACA. We also know that uninsured rates among working age women look different by region, by state. You can see that there are the states in the lightest blue color have the lowest rates of uninsured working age women. The darker blue have slightly higher, and the orange really have quite high, persistently high rates of uninsurance among women. And many of these states in orange have not yet expanded Medicaid or were late to expand Medicaid. So this is likely driving some of what we're seeing here. There are also some really important disparities that persist in uninsurance rates by race, ethnicity, and by citizenship status. So you can see the orange on the bars on the bottom of these clustered bars are showing rates of uninsured individuals. So you can see Hispanic, Asian, Hispanic and other Pacific Islanders really have quite high rates of uninsurance relative to white women, and non-citizens continue to have really high rates of uninsurance. So still some more work to do here. I think the key takeaways with regard to coverage are that we've seen some important wins in the areas where the ACA intended to have effect, with really large reductions in uninsurance among working age women and some key subpopulations that were quite marginalized in terms of coverage prior to the ACA. But lots of work still to do in terms of focusing on equity and policies that will center the needs of those who continue to be marginalized in this post-ACA era. So let's pivot a little bit and talk about affordability. I want to mention two key indicators of healthcare affordability. One is financial hardship, which is folks' perceived distress due to healthcare costs. And the second measure is out-of-pocket costs. Objectively, what do we measure that people are paying for various healthcare services, and what have trends looked like over time? So in terms of affordability, one piece of good news has been that there have been really important declines in reported health-related financial hardship among women overall. And some of the data on this slide come from the National Health Interview Survey. It's a nationally representative sample of U.S. adults. So folks telling us that their healthcare affordability has improved. Some of these data also come from difference in differences studies, which are really elegant econometric type study designs that allow us to look at trends over time in a group exposed to an intervention and a group that acts as a contemporaneous control that was not exposed. And so these difference in differences study designs have allowed us to look at Medicaid expansion versus non-expansion states in order to generate some of these data. So these studies suggest that women are expressing less difficulty finding affordable coverage. Fewer folks are feeling worried about paying for care. Fewer folks report cost-related unmet healthcare needs. So cost is less likely than before the ACA to be impeding folks from accessing recommended services. And fewer women are reporting problems paying medical bills. So all of those things are reassuring. The bad news is we continue to see persistently high financial hardship among some subgroups of women. Peripartum women are a really great example. This is some preliminary data from one of my amazing mentees, Dr. Catherine Taylor. She is a surgery resident who's spending 2 years with us during her research time during residency. And she's demonstrated using the National Health Interview Survey that financial hardship is quite common and in fact has not changed substantially in this post-ACA era. It affects 7 in 10 peripartum individuals. And when we looked based on insurance status, privately insured women compared to publicly insured women had lower unmet healthcare need, but higher healthcare unaffordability. And this is perhaps unsurprising, reflecting that Medicaid plans generally do not have very much or any cost sharing for pregnancy-related care, whereas commercially insured plans can have quite high cost sharing. Similarly, we looked at lower income individuals and they had both higher unmet need and higher unaffordability. And it's important to remember that although Medicaid is a major payer for many folks living on lower incomes, employer-based insurance actually is as well. So employer-based insurance plans provide health insurance coverage for about 25% of those living on incomes less than 200% FPL, and over half of individuals living on incomes of 200 to 400% FPL. So we know that we need to be thinking about both commercial insurance benefit design as well as Medicaid plans when we're trying to understand affordability among lower income families. What do we know about out-of-pocket costs? I mentioned the preventive care clause. This is section 2713 of the ACA, and it was a really important effort to try to say preventive services deliver high value for patients, and therefore we should not have any financial barriers to accessing these services. And so the ACA required that any service with a USPSTF rating of A or B be covered without cost sharing, no copay, no deductible payment, no coinsurance payment. And this has really been the gift that keeps on giving, because as new services get a rating A or B, they become subject to this clause. And I won't present a ton of data on all of these different services, but I will just share that we know from a robust literature now that out-of-pocket costs for these services fell quite rapidly with the implementation of the ACA. So services like mammography, contraception, health maintenance exams, these bread and butter services that we recommend for patients, cost sharing fell very quickly. However, we also know we still have a lot more work to do. When you look at the percent of working age women who have out-of-pocket healthcare costs of $2,000 or more annually, we are an outlier. The US and Switzerland, you can see, compared to our other highly resourced peer nations. So lots of work to do, and it raises some questions. If folks aren't paying for preventive care, what exactly are we paying out of pocket for? Well, one major area of spending for families is maternity care. We did a study where we looked at about 400,000 women in commercially insured health plans from 2008 to 2015, and we found that spending was really rising precipitously for maternity care over the years of the study. Out-of-pocket spending for maternity care was nearly universal, with 98% of families in 2015 having at least some out-of-pocket costs for this care. And the mean total out-of-pocket spending increased to approximately $4,500 in the final year of the study. And the teal line at the top of the bar graph here shows you that trend over time. And the y-axis here is dollars, the x-axis is time. And the yellowish orange bar shows you coinsurance payments. You can see a small rise and then sort of tapering off, plateauing. The darker reddish orange line here shows you deductible payments. You can see that it's really the deductibles that are driving the overall trend, with co-payments down at the bottom, pretty low, pretty flat line there. We've furthered this analysis by looking just at childbirth hospitalizations and looking across the family at the maternal-infant dyad, looking at costs that families have for both mom and baby, and saw that just the childbirth hospitalization alone leads to median total spending of about $3,000. Again, this was highly prevalent, affecting almost all families in the study. And for some families, these costs exceeded $5,000. For those who had a C-section or a NICU stay, costs were much higher. I think I just saw a note that maybe the slides reverted. Do I need to maybe stop sharing and reshare one more time?
I think you're fine.
Oh, okay. All right. I will start sharing one more time here. Okay, can folks see the slides okay?
They look good.
Okay, all right. So this research looking at folks' out-of-pocket costs for medical care really resonated with the public. I think I had mentioned earlier in the talk that maternity care is the most common reason that people utilize their health insurance plans. And so there was quite a bit of outrage in response to our studies about why folks were having to pay so much for this very common healthcare service. And another major driver of those out-of-pocket costs may be that catastrophic spending remains high. So for folks with a cancer diagnosis or a trauma evaluation, surgery, hospital stay, these sort of unexpected, unexpected health diagnoses that require intense healthcare, that catastrophic spending may be another driver of these out-of-pocket costs. So when you look at catastrophic spending, which is defined as spending exceeding 40% of one's income, that overall levels of catastrophic spending dropped from 2010 to 2017. But if you look at that teal box in the middle of the graph, these are privately insured individuals, and you can see that they comprise over half of those with catastrophic spending, and the height of that bar really hasn't changed over time. So this is really the group that is suffering from this problem. We also know that among those in the lowest income quartile, privately insured individuals who in low income households had no change in catastrophic spending and had the highest rate of catastrophic spending. So this is really the group that we need to be concerned about and thinking about policy change to help. So some key takeaways on affordability. We've definitely seen some positive signs related to reductions in financial hardship due to healthcare, unmet health needs, and cost sharing for preventive care, and even some chronic disease services, but growing concerns about financial protections for working families with employer-based insurance due to strikingly high costs for common acute events like childbirth. So let's pivot one more time and think about what we know about utilization and health outcomes. How have these changes with coverage and affordability led to changes or not in utilization of healthcare and health outcomes? So I'd love to talk for just a minute about contraception as really a case study for many other preventive services, mammography, health maintenance exams, vaccination. We've certainly seen that Medicaid expansion is associated with improved access to contraceptive care. We also know that in studies that have examined employer-based insurance plans, that really precipitous fall I mentioned earlier in out-of-pocket costs has been associated with increased use of contraception and use of the most effective method. So that's really reassuring. We've also seen reductions in income-related disparities in unintended birth rates. So the unintended pregnancy rate in this country is 45%, much higher than our peer nations. It was an area we've had a lot of work to do for a long time, and it was really, really exciting to see that the ACA helped us move the needle a little bit on those unintended birth rates. It still remains to be seen whether this increase in use of contraception will actually affect downstream maternal and neonatal outcomes and abortion rates. So the jury's still out on that. What about perinatal outcomes? Some of those differences studies that I mentioned, often comparing Medicaid expansion to non-expansion states, have suggested really important benefits in terms of improved use of recommended screenings in early pregnancy, increase in maternal postpartum service utilization, particularly among those with severe maternal morbidity and mortality. So a really important finding for our field. And we've also seen reductions in infant mortality that are higher in states with Medicaid expansion than without. So really important findings about the benefits of Medicaid expansion for perinatal outcomes. We have not seen similar changes in preterm birth or low birth weight, although there have been some reductions in Black-white disparities in preterm birth, and we have seen reductions in preterm birth rates among dependents who are benefiting from that dependent coverage clause, those young adults 18 to 26. So those findings are reassuring. In terms of other services, we've seen some kind of mixed results. So when you look at cancer care and screening for cervical cancer, breast cancer, other gynecologic cancers, we've seen some kind of mixed results. And this may be because the Affordable Care Act's Preventive Services Clause is really applied to the first step in screening. So, for example, with cervical cancer screening, a pap smear and an HPV test are covered, cost-free for insurance enrollees. But if you have an abnormal test, your colposcopy or your LEEP or conization would not necessarily be covered without cost sharing. Similarly with breast cancer screening mammogram may be covered, but if it's abnormal, the diagnostic mammogram may not be. So we've seen some kind of mixed results in whether the ACA has led to increased utilization of screening, particularly among subsets of the population. We have seen overall an increase in early stage cancer diagnosis for many types of cancers, and there will be certainly more work coming forth in upcoming months to look at how the COVID pandemic has affected some of these gains. In terms of mental health, we've seen higher screening rates for mental health. This makes sense if we have more folks who have health insurance coverage, have access to a primary care doctor. We've also seen some improvements in symptomatology and self-reported unmet mental health needs. There is still a lot of work to be done, particularly in our field, in looking at things like mental health and pregnancy and how the ACA and related policies have affected patients who have mental health diagnoses and potentially unmet needs during pregnancy and postpartum. We've also seen some improvements in diagnosis of chronic diseases, a little less benefit on the disease control side. And this again may reflect that preventive services clause focusing more narrowly on preventive care. Interestingly, the IRS recently, about 6 months ago, released guidance that high deductible health plans are now allowed to cover common services for managing chronic conditions like diabetes and hypertension pre-deductible. So, the U.S. Department of Treasury is sort of interpreting that preventive services clause a little bit more broadly, that this isn't just what we would clinically define as screening services per se, but actually that the spirit of that provision was to provide cost-free coverage for many types of services that prevent disease progression and complications. We've also seen a few studies coming out looking at mortality. We've seen overall improvements in mortality rates in the United States, with some studies showing benefits across different age groups and some disease-related mortality improvements as well. And there is one systematic review that shows some really great findings around self-reported health. We've seen substantial improvements in self-reported health for young adults, again, those benefiting from that dependent coverage provision, and some more mixed results for Medicaid enrollees. Interestingly, very few of these studies have estimated separate effects by race ethnicity, and we know that there are still gaps in coverage across racial ethnic groups in the United States, so much more work to be done to really understand what's going on across different segments of our population. So my key takeaways around the ACA's effects on utilization and health outcomes are we certainly have some positive improvements for some important population health outcomes and have lots more work to do to understand long-term effects on health and health inequities. So with what we know about the ACA's effects to date, what are some emerging policy priorities? I don't have a crystal ball, but when I step back and look at this landscape, I think there are two really hot topic areas where we are going to see policy changes happening in the next 5 years. One is coverage for perinatal populations, and the second area is really trying to address some of those affordability and medical debt slides that I mentioned earlier in the talk. So let's talk about each of those in turn. In terms of coverage for perinatal populations, we've seen some improvements due to the ACA related to Medicaid expansion. So this study shows you unadjusted trends in the proportion of perinatal individuals, pregnant, birth, and postpartum, who transition from insured to uninsured status at some point during that period of time. These are all low-income women in Medicaid expansion versus non-expansion states, and the y-axis shows you percentage. The x-axis shows time, 2012 to 2017, and states were classified based on their expansion status in 2014. And the orange line at the top is non-expansion states. The teal line on the bottom is expansion states, and you can see that the ACA's effects sort of broadly improved coverage for lower income perinatal populations with that orange line, but the effect was much more pronounced in Medicaid expansion states. So this suggests that we have more work to do trying to help states that haven't yet expanded Medicaid to expand their programs. We also have reassuring data that uninsurance rates overall are falling for postpartum women. This is such a critical factor for our field. We know that maternal mortality, about 50% of cases affect postpartum individuals. So it's really important that folks have health insurance coverage during this period of time. To reduce maternal morbidity and mortality, as well as to address chronic conditions. About 1 in 5 pregnant individuals now in the United States has a chronic condition, diabetes, hypertension, depression, anxiety, and it's very difficult to treat those conditions and kind of bend the trajectory towards progression, towards complications, if we don't have folks having health insurance coverage and access to our system. So one of the reasons that we see such kind of prevalence of uninsurance rates in postpartum populations is that Medicaid eligibility is much more restrictive for parents than for pregnant women, particularly in states that haven't expanded Medicaid yet. So if you look at the y-axis here is the FPL, percent of FPL where folks are eligible for Medicaid coverage, and the blue bars show eligibility among pregnant women, and the orange bars show eligibility among non-pregnant adults. And you can see that these income eligibility criteria, these orange bars, are just much lower than they are during pregnancy. And you can see the orange dotted line running across shows you that 138% level where if these states expanded Medicaid, that would become the new eligibility level for postpartum non-pregnant individuals. So in addition to Medicaid expansion, folks are also thinking about extending postpartum Medicaid coverage. So those pregnant eligibility criteria, extending those for 6 to 12 months postpartum. And the states in gray have not yet taken action on this, but all of the colored states have either introduced and enacted or implemented legislation to try to extend their pregnancy Medicaid coverage for that full year postpartum. So I think we will continue to see movement in this space, potentially federal policy that tries to improve this for women across the country with, in the meantime, these ongoing innovations in state programs. What about affordability and medical debt? Some of my prior slides suggested this continues to be an emerging kind of pain point in our healthcare system for folks. We know that many families are facing rising spending for healthcare. Average premiums for families increased 55% over the last decade. So this graph shows on the y-axis is percent increase, on the x-axis is time 2010 to 2020. And that orange line at the top shows you rise in deductible payments. The blue line is rise in family premiums. And you can see that both of these lines vastly exceed the temporal trends in terms of rise in workers' earnings. So this maybe explains why a full 1 in 5 families in the United States are underinsured. And this is mathematically defined as families that have premiums and out-of-pocket costs, those deductible, copay, and coinsurance payments that exceed 10% of their income. And this has led the Commonwealth Fund to call this a looming crisis in affordability in the United States. A paper published in JAMA just last month suggests that nearly 1 in 5 U.S. adults have medical debt in collections. So this isn't, credit card debt that's being paid off. It's debt that's actually gone to collections. And we know that the prevalence of medical debt is highest among individuals living in the South, those in the lowest income households, and those living in states that did not expand Medicaid. So it has led to some of my colleagues calling medical debt the new social determinant of health, that we have to figure out a way to ensure that folks who are utilizing recommended evidence-based care are not going into debt because of that. So what are the solutions to some of these challenges that we face in our healthcare system right now? I think there are some great opportunities to take what we've learned about the benefits of various ACA policies and try to expand coverage. So I mentioned those postpartum extensions of Medicaid coverage. Medicaid expansion in states that haven't yet expanded is certainly a goal. We know that there are huge benefits to this kind of policy change based on the last decade of research that has emerged since the passage of the ACA. The Biden administration campaigned on making a public option available. We've heard a lot less about that since the current administration took office. So we'll see whether that becomes an option that's on the table for people. There are also ongoing conversations about marketplace subsidies and whether we can enhance those subsidies to offset the cost of premiums and cost sharing for folks who are not in employer-based plans, but are individuals buying health insurance on the marketplaces. These subsidies certainly need to be available to folks who are in non-expansion states with incomes up to 138% FPL. When the original ACA marketplace subsidies were put into place, everybody thought that Medicaid expansion was going to happen across the country. And so those who are living in states that have not expanded Medicaid, that don't have access to Medicaid and are under that 138% FPL range, don't really have the same financial supports as other lower income families to purchase their health insurance plans. There are also lots of opportunities to start improving affordability of health insurance coverage. Our team does a lot of work on value-based insurance design, and that term was coined by Mark Fendrick, one of my colleagues here at the University of Michigan. And VBID principles were baked into the ACA, including in that preventive services clause. And the idea behind value-based insurance design is that we should eliminate cost sharing for things that we know deliver high value for our system. So evidence-based services that are cost-effective, we should be eliminating out-of-pocket expense for families for those services. Conversely, things that don't deliver high value for our healthcare system, services that are high cost or even not high cost but not delivering improvements in outcomes, should not be covered by health insurance plans or should be covered with significant cost sharing. We know that cost sharing even small amounts of cost sharing, $60, $70, $80, can impede people from utilizing recommended care, such as recommended medications, vaccines. And so that's kind of the principle behind VBID, is to provide coverage without out-of-pocket cost for high-value services, and to make that cost neutral by eliminating coverage for low-value services. There are lots of opportunities as well to start expanding interpretation of the ACA's Preventive Services Clause. We talked a little bit about how the Department of Treasury has released new guidance suggesting that services that help prevent progression of chronic diseases and the development of complications and costly ED and hospital stays, that those things can be covered by plans under the preventive services provision. And I think we will start to see more expansion of that interpretation into other areas as well. Pregnancy is another area where this policy has not been particularly well defined. So certain services in pregnancy, such as vaccinations and screening for diabetes, are covered under the Preventive Services Clause. Other services, such as prenatal visits, where one might need to go in order to obtain a prescription or an order for some of those services, may not be covered without cost sharing. And childbirth, for example, not covered without cost sharing. And so I think there are ongoing conversations happening about what kinds of policy changes might help address those pain points for people. So I'm going to wrap things up there. I want to thank you so much for your attention. I know many of you, like me, have been working from home on your administrative days. These are my new coworkers here, and if 2 out of 3 are smiling on any given day, it's a pretty good day. I'm so grateful for your attention and your just invitation to spend this time with you this morning. And I'd be so happy to hear your thoughts, your comments, or answer any questions that you might have.
Thank you, Dr. Moniz. That was awesome. It's so good to hear that there are strides being made in covering more preventative services. I do want to open up the floor for any questions for her.
Hey, it's Heidi. Dr. Moniz, fabulous talk, really interesting and compelling. Do you have advice for people who want to get involved in moving these policies forward? How can the busy OBGYN who isn't a health policy or implementation scientist expert move the needle or help with this work?
Hi, Heidi. Thank you, Dr. Brown, for that question. That's such a good question. I think we sometimes forget how privileged we are to be in rooms with people from all walks of life. We really see such a broad swath of our society, and we hear people's stories. And for all the data that we've talked about today, what really changes hearts and minds is patient stories. And so I think finding ways to partner with people that do have that policy expertise, to get in the room with elected officials, with insurance leaders in your state, folks who are making decisions about benefit design in the commercial plans in your area, getting in the room with those folks and sharing some of what you've noticed in your OR, in your office, in caring for patients who are hospitalized. About how their benefit design is affecting your decision making and patients' ability to actually access the care that is recommended for them. Those stories are incredibly powerful. So I think that's one approach. Another approach is to think about using your voice. We can write op-eds. We can talk with folks in the media about studies that are coming out, about policy change that's happening. So I think there are ways to be really creative about kind of leveraging and tapping into the privilege that we have as physicians and other healthcare workers in our society.
It looks like there is a question in the chat box. The question is, any policy being developed to support those in our country that are not eligible for Medicaid/exchange options and remain uninsurable except when pregnant?
I think this question may be about folks who are eligible for emergency Medicaid. I know there is advocacy going on in that space, but I do not know of any kind of legislation that has started moving its way up to the top yet. Unfortunately, it's certainly an area where we need more attention.
Dr. Moniz, it's Katie Sempene. I just wanted to say thanks for your talk this morning. And it was really inspiring for me. I think it's one of my colleagues here we're holding down the fort. But it was really inspiring for me. And so thank you for presenting to us and helping us understand this better, as well as your mentorship, just like broadly and specifically to me over time. So I just wanted to give you a huge shout out and thanks for the work that you're doing, because it impacts our patients here over in Wisconsin as well. And really exciting stuff I know coming down the pipeline with your new work as well. Looking at the quality initiatives and things like that, I think are fascinating. So I hope that we can maybe hear back from you in the future about how some of that work goes for you. Thank you.
Oh, thank you so much. And thanks for logging in while you guys are busy on labor and delivery.
Hello,
Good to see you.
this is Gloria. Can I ask a question?
Sure. Hi, Gloria.
Hi. I'm sort of interested in, I do a lot with the Black infant mortality rate that we have in Wisconsin. And I was wondering if you looked at some of this insurance issue, even extending the postpartum care coverage for a year might be helpful in addressing some of that. And I'd like to know what you think about that.
Yeah, thank you, Gloria. What a great question. And thank you for the work that you're doing in this really important space. The data we have do suggest benefit of Medicaid expansion, and we can think about that as potentially benefiting in that postpartum space, right? Because in states that have expanded Medicaid, folks who otherwise may have lost their coverage postpartum are now eligible to continue, not because of pregnancy eligibility, but because they meet this higher non-pregnant income eligibility threshold. So it certainly looks like extending postpartum Medicaid coverage and Medicaid expansion will be helpful for addressing some of the racial disparities that we see in maternal morbidity and mortality, infant mortality, potentially in preterm birth. We've already seen some of those benefits just from Medicaid expansion more broadly. So I think there are a lot of reasons for us to be continuing to lift our voices and advocating for those extensions of postpartum coverage.
Yeah. Thank you.
Sure.
I have one quick question. This is Bala Bhagwat. Thank you so much for your wonderful talk. I hold University of Michigan as my hero and role model because I'm an REI, and University of Michigan successfully rolled out a coverage program for its employees. Here I have decided to take it head on, not only fighting at the institutional level, but also at the state level. I'm curious if there's any effort from the university's behalf for extending that coverage at the state level in Michigan.
That is a great question. You know, I guess first of all, I would say if you aren't already, I'm happy to connect you with colleagues who have been instrumental in that policy change here. For folks who may be unfamiliar, our health insurance plan here for all employees and staff across the university made the decision to provide coverage for IVF for our staff and employees. And the rationale for that was that our REI docs agreed to be implanting one embryo and one embryo only in the majority of our patients, with the idea that by adopting that approach, we would eliminate more complicated and more expensive maternity care. And that is still being studied right now. So there are a couple different grants and investigators that are working on understanding what the effects of that have been. And I think once we have that data, we will be much better positioned to be able to successfully advocate for broader coverage. I don't know if those conversations have already started with other commercial payers in our state, or if this is still kind of more at a pilot level. But happy to connect you with folks that probably do know that answer.
Thank you.
Sure.
Any other questions? Okay, well, Dr. Moniz, thank you so much. It was so nice to see you, and thank you for coming to talk with us. We can pop off just a couple minutes early here. Have a good day, everyone.
Thank you all. Take care.
Thank you.
Bye.
Thank you.